Can I take this off? Good. Okay, everybody ready for this one? You guys better be ready for this one. I'm going to surprise you all. All right. What's today's talk? All right. This one's near and dear to my heart. And the best way to bring it up is to put in the history, because you guys know I like to do that. So, anybody want to try to guess when telemedicine started? I enjoy the laughter. I enjoy everybody thinking what they're thinking. And that's why today's talk is what it's going to be. Because everybody misunderstands what telehealth and telemedicine is. And that's why I needed to talk to you, because the whole world has changed, as we all know. And everybody needs to understand what's coming. I hope one thing you guys can admit, because I've been doing this for many years up here, is I'm way ahead of anything else that anybody else has ever heard. And that's why this was the topic today, because no one understands what's really going on in healthcare. Okay? What does tele mean? Thank you. And the Romans did it in 500 BC when the physicians couldn't get to the communities. And so they would send couriers out to relay the medical information. Does everybody understand what I'm talking about? Everybody doesn't have the true concept of what is upon us in healthcare and what is coming. Remember that. Distant. That's what that relates to. And has anybody heard anything recently? You know, home care at home, right? Stay at home. What does that mean? They're coming to you. And what does that mean? That's what we're talking about today. So I'm glad everybody got a laugh out of the 500 BC. I thought that was a pretty good start to it as well. But what I found was when I did the history, I did it because of what I was seeing personally. And what I was seeing personally is telecommunication, distant communication via the sound waves is phenomenal. And since the 1800s, things have been being passed along. A Dutch physician, I think in 1894, sent the first EKG over radio waves. So there's definitely benefit to communicating long distance with the new technology that we have. But I brought up telehealth and telemedicine and threw this up here first so that everybody understands, if we've been doing it since 500 BC, then why isn't it perfected by now? Okay? And I mean perfected. And what I found was COVID opened my eyes. What were we told when COVID hit? We could do, what was it called? Zoom. Zoom visits, and Medicare would reimburse us. So my schedule goes out about 3 months. Okay, what that means is that patients that come and see me regularly in my office, we follow up depending upon their diagnosis, say quarterly. And so my schedule goes out that long. And when we were told by Medicare when COVID hit that if we did Zoom, we would be reimbursed, we kept our schedules. And what did we find that was neat? I tell patients that they're like my children when someone comes to their house. Showing off, okay? Like someone comes in to visit you in your home and they ask you questions, and the information provided back and forth sometimes takes up a lot of time. So what did I find with Zoom? In my office, I schedule a half hour for patients, and generally that's plenty of time for whatever we need. Zoom, it wasn't. All of a sudden, like I'm seeing them in their home situation, and it's 20 minutes till we get to the questions that I have to ask. And then again, I can't examine you because you're in a house and I'm not there, so I'm asking questions and we're interacting and we're talking about things, and we send off our bill. And I'm here to tell you that we got about 12% of what we expected. And don't forget, I told you, I already had a full schedule, and it takes now for Medicare to reimburse us. I'm independent. It takes 2 weeks for me to get money back from Medicare. So that whole cycle went, so it was about a 5-month period of time, and when we saw what happened, we took a big hit. Fortunately, money was made available and we survived, but it made me realize there was something else to this that we had to get to the bottom of. So what I did from, I think it was 2020, actually. So what I did was I tried to decide, what does telecommunications now, we're changing that, not telehealth, telecommunications, I can't spell, communications, provide. I'm sure you guys, it's Christmas time, I'm sure you guys have seen that new thing where you put your fingers down and it gives you an EKG, okay? You think that's something significant, it's not. It's what we call a rhythm strip. A rhythm tells us nothing other than your rhythm. It tells us nothing at all about your heart. Zero. It tells us about the rhythm. So what does that mean? You could take your own pulse and figure out your rhythm. But the way they're selling it is that if someone has heart disease, this is good for you because this can give you an accurate reading of the heart and what's going on in the heart. My whole purpose to the point of this is the information that you're getting on what's coming out there, pay attention. So what I wanted to talk about first and foremost is what's being provided. The last I looked at this was 2012, and Obamacare came in 2010, and I saw the ICD change. ICD stands for International Cause of Death. International. So for centuries, we've been interacting with every country in the world to see how their causes of death, number 1 to number 10, vary and different from ours. It's a good exercise on healthcare. It provides a lot of information. It's a wonderful situation. The ICD code in 1994 was ICD 9. All European countries adopted it. America didn't. We had a different healthcare system, okay? I didn't understand it when I was going through residency. I didn't understand it when I finished and got into practice. I thought all it was the international cause of death. I soon found out what it was. Remember, 94, all of Europe went with ICD-10, ICD-9 that was changed to ICD-10 in 94. I think I said that wrong earlier. America didn't go till 2010. Coincidentally, that's when the Accountable Care Act went through, otherwise known as Obamacare. Why do I bring this up? The foot. I only gave him 4 toes. Sorry about that. Okay? ICD-9, and this is just general. It could be more. ICD-10. ICD-9 had 21 options to code for the foot. ICD-10, 140. I heard that. What does that mean? For those computer people out there, with 140 variables to the foot being filled out in a computer system today, you can draw the foot. What does that mean? You don't have to see it. Does everybody follow me? The computer gives you the image of exactly what's there based upon the coding that's provided for that particular extremity. Does everybody understand the concept? Because what I'm building here is the distance health that's coming is stay at home. And we're going to talk about this. This is all driven by dollars. But that's what's coming. And no one heard this till today when I threw up the 500 BC. We've been dealing with telemedicine. So they're making you think it's telecommunications. It's not telecommunications. They're coming into your house to see you. That's what they want to do. And I'll build that from right now to why. But I'm emphasizing the fact that the ICD-9 code that had 21 ways to describe it. Distal, proximal, toes, what exactly they are, ankle joint, fibula, tibia. For doctors to communicate, as I did since the 90s when I got my license, all we needed in America was 21 ways to describe it to another doctor, and that other doctor knew exactly what we were talking about. Everybody follow me? Now, the 140, the 18-year-old doing computer data analysis, once they put the data in, could hit a button and see that leg and see every aspect of it. Yes?
So it's a generic leg according to the code.
What do you mean generic?
Well, it's not a picture of your own leg.
Depending upon who put the data in. If it was someone coming to see you and they coded it, it would be your leg. And if you've seen somebody that has a computer system, that data is available to you. It's called a matrix. That's the term. If anybody here has seen a physician that has a computer, you have a matrix. That matrix is your health care. And that information that you provide them when you go to the emergency room, when you go to doctors that are computerized, and very soon when they come into your house, and I'm sure they already have. You might not have let them in, but I guarantee everybody in here has had a phone call that your insurance is providing a free such and so, and oh, by the way, you can get an umbrella or a $25 gift certificate or whatever else it happens to be there. They want to be in your home. They want to come see your environment. They want to come talk to you to develop the matrix. Everybody follow me? And so the information that they're inquiring about, I'm not sure if it's to your benefit to have them in your house treating you because the data is not here for us to review. Cost is down for the insurance companies, we know that, but I still don't have the data. Now, remote places, like if you're living and the closest health care is 200 miles away, I'm all for telemedicine. And I'm all for if someone could come see you, that's a wonderful situation. But overall, I want you to have this concept as we develop it, okay? Does everybody understand what I'm talking about? So the ICD-9 and the ICD-10 code, let me give you an example. I could write on the chart, Mrs. Jones has chronic venous insufficiency. That means the veins in her legs are dilated, so I see blue streaks in her legs. And because of this, she has venous stasis. That means that the blood in the vein stays where it is instead of flowing back to the heart. And this has led to a stasis ulcer. Does everybody follow me? So my description on the ICD-10 code would be chronic venous insufficiency with right lower extremity venous stasis ulcer. Does everybody follow me? Now, and that takes me 2 minutes. I see Mr. Jones. I write that down, put the chart, go. Back in that day, when I first started, the patients would pay me cash. I would turn that into Medicare, and they would get a check for whatever I charged them 100% within 5 days, 1990. So I would write that, send it in, patient gets the money back. Now, the information I have to put on the chart not only takes time because this is my speed, but it also is more information than I generally provide. So now they want to know the circumference of the calf. They want to know exactly where it's located on the leg. And once again, does it change the medical management? Does it help get that ulcer better faster? In my experience, 32 years, no. What's the information for? The matrix. Why is it in the matrix? I'm going to develop that. So everybody follow the concept that we're going through. So I'm using the leg. 1994 till 2010, and I practiced in those years the 21 ways to describe this foot. Didn't cause any illness or harm to any patient that I managed, and I had quite a few patients in that time period, guys. I went to 3 different nursing homes. I had more admissions at Passavant Hospital, Allegheny General Hospital, St. Francis Hospital, and Suburban General Hospital than any doc in the city of Pittsburgh. And that was because I took care of nursing home patients. And back in those days, you were allowed to stay as long as you needed to at both the hospital and at the nursing home. And so my experience is what I'm sharing with you, and my experience showed this provided quality care for a lot of patients. I'm talking thousands, 4,000 or 5,000 patients easily in that period of time I took care of. And that was enough information. And when I would call the surgeon and give them a description, because it's still the same disease. If you have diabetes, there's trouble with the vasculature. If you smoke, there's trouble with the vasculature. If you drink too much alcohol, there's trouble with the vasculature. All of us have chronic venous insufficiency because we sit too much with our legs and knees bent. So what happens? You either treat it, work on it, wear the support socks like I do, or you may end up in one of those situations. What happens now is once they have the information and they come to your house, they're going to document. And what does that mean? Well, to go to the hospital to get a stasis ulcer repaired, they have to do a catheterization and send blood, a medicine to show dye go through the artery to see if the blood vessel's open. If it's not, they open it up with stents, just like they do with the heart. And what we're seeing is, depending upon how well you follow the directions to keep it well, sometimes you don't get that surgery right away. Does everybody follow me? Again, pay attention to who's talking to you and especially who's coming out to your house. Let me set up how it all went from what I saw myself. All right, so this is the concept of the ICD code. We're going to come back to that. I started practicing in 1990 with a gentleman by the name of Dr. Potter. I was working Monday through Friday, 9 to 5. And he told me, nope. Monday, Wednesday, Friday, you go to the nursing home. In 1990, I didn't even know what a nursing home was. I didn't understand the concept. And he said Tuesday, Thursday, and Saturday, you see patients at night and all day Saturday. And he said you'll have more patients than you can imagine, because that's when the people that have the time to come see the doctor will be able to come and see you. And what he advised me back in 1990 has indeed worked. And he also was not a Medicare provider. And that's how the patients got charged cash. And within 4 days, they were reimbursed 100%. I'm not complaining. Don't get me wrong, guys. I'm very happy. Lived a wonderful life being a physician for all these years. Raised 6 children. Have another one getting married in a month or so. It's been a great life. Don't get me wrong. But 100% went back to the patient from the cash they paid 32 years ago. 2 weeks for us to get reimbursed. We're lucky if it's 40 to 60%. And if you don't have the right codes, you don't get paid. I'm flip top, and I'm not computerized. Does everybody follow me? And it's the way the system works. Advantage, disadvantage. What's the disadvantage? Commercials. Is there an advantage to the patient getting the information from their blood work within an hour of the time the blood work has been done. And I'm talking advantage, disadvantage based upon your health. The way I practice is if you're at that point where I'm so concerned that I need to know right away, you're going to the hospital. If you're not going to the hospital, I'm not acutely concerned about what we're ordering and how we're treating. So what I find now is my chart and some of these other things, the increased volume of calls to my office because patients now have the data and they want to have it interpreted now. Does everybody follow me? So what the disadvantage to me is the commercialization of healthcare. It's not connected to true health. What does that mean? What I would prefer is the patient making sure, or the company making sure that the patient gets literature on an elevated cholesterol or an elevated A1C or an abnormal lab of some other type, which they have the resources to do. And that, for me, would be a benefit to the patient. So that distance travel to try to work on their health for quality of life, I welcome. That's not, unfortunately, where we are at the moment. What I see is the systems, I'll put the systems, are looking at cost. How do I know it? I can't report what system it was, but I'll tell you in 2016 was my first look at telehealth. I was working for a reputable company that had what they call an LTAC. Anybody ever heard of an LTAC? Long-term acute care. Long-term acute care. Remember, guys, I've been doing it since 1990, and I started out in the nursing home seeing thousands of patients. Long-term acute care. What that means is we don't take care of the patient in the hospital long at all anymore. So they have acute care needs, but they're longer than the acute care hospital can take care of them. So they opened up around the world, and here in Pittsburgh, 3 different places opened up for the long-term care services. And when we were covering the long-term care services, they had a thing that was called recidivism. I'm not even going to try to spell it. What it means is if the patient gets transferred to your facility and comes back into the hospital with the same problem within 30 days, we are not going to pay you. Does everybody follow me? 2016, so that's 6 years ago. Length of stay. Anybody heard that term? You remember the ICD code I told you about, right? Well, the other one is called CPT code. And then they also have the diagnoses that they put together, they lump in with days that you're allowed to be in the hospital. I tell the story, 1983, I was in Baltimore, that's where I trained, June and July. June 30th, July 2nd, we were on call every couple days. June 30th, I had a patient admitted with pneumonia. I go down to the emergency room, look at the x-ray, go examine the patient, write the orders, go to bed. July 2nd, patient with pneumonia. I come down, look at the x-ray, examine the patient, write the orders, go to bed. I get called that I have to come down and do a gram stain. Anybody know what that is? You have the patient spit, and you take the spittle, and you put different mixtures with it and look under the microscope to determine the bacteria. And by looking under the microscope, you can tell if it's gram positive or gram negative, and they would start the antibiotic in the emergency room. This is 1983 pilot program for what's called DRGs. Diagnostic Related Guidelines. This is the key. These are guidelines. So what they determined was if you would identify the organism in the emergency room and be close to honing in on what it is, that we can get the patient out of the hospital faster. Does everybody follow me? So 1983 began the length of stay situation, and again, it was for DRGs, Diagnostic Related Guidelines. And again, guys, this is my personal experience. I was there. So it was 1994. I'm at Suburban General Hospital, and you have to understand how rounds were back then, guys. You can't imagine compared to today. I used to come onto the floor. The nurse would bring my charts, and like I said, I had a lot of patients, so there might be 16 charts stacked up. And we would sit face to face, and she would take one chart after the other, and we would talk face to face about every patient. And she, as the charge nurse, every nurse would come to her and tell her, did they have a bowel movement? Did they sleep? Did they eat their breakfast? Did they move their bowels? All that information I got face to face. That's how things were in healthcare, 1994. So I show up on the floor one day, no nurse. Where's so-and-so? Oh, she's in the back with the case manager. Now remember, guys, no one talked to doctors before this happened. So I said, what's a case manager? Who's the case manager? I never heard the term before. And so one of the other nurses came out, and she said to me, oh, Dr. Coppola, that's the new system with managed care. And I said, what's managed care? Once again, we didn't know about it. This was all being piloted in the hospitals. So I didn't have my charts on the floor for the first time since I was practicing for 4 years. So I asked, where do I find them? Here, this person had an office with a desk and all this information and a computer. Everything was set up. And so I went in, and she was telling me, based on the guidelines, this patient should be discharged by this day. Based on the guidelines, this patient should be discharged on this day. So from 1983 to 1994, the guidelines became part of the healthcare admission. Does everybody follow that? So now the changes that occurred from 83 to 1994, we were moving to a length of stay in the acute hospital, and I'll put 3 days here, and pushing to the LTAC, and of course, inpatient rehab and skilled nursing. So this is how the system ran, let's say in 94. Now, the LTACs are gone. So they've managed to get the length of stay down in the hospitals to get you out either to an inpatient rehab or skilled. Well, what are they finding? It's not working. Still a lot of cost. So that's why what you're hearing. Care at home. Wonderful care at home. They can come to your house and take good care of you. Is it wrong? No. I'm not suggesting that it's wrong. It's still good health care. It's quality health care. People would rather be home. But don't miss, based on terms, what's truly happening. And what's truly happening is they can check you from head to toe, and with the system that's set up, they have all your medical information in there, including your medications and your habits. You know, so the diabetic that's not supposed to eat sugar and is on insulin, and you know, some of these new medications that are out there, they're going to document what you eat. They're going to document what's in your refrigerator. They're going to document the things that you're telling them when they're asking you the questions. And once again, don't forget what I told you. When my kids get visitors, when they were younger, I call it showing off. You know, so the information you're provided is a little bit more than generally you provide. I'm not warning anybody. I want everybody to be honest, but I want to make sure who's asking you the question. And generally, we get the call that it's your insurance company. So say you have Medicare A, and Medicare A calls you up, and Mrs. Jones, it's Medicare A. We have a free physical that we'd like to provide you with. You know, we can come out, want to set up a date and time now. This will really benefit you. And oh, by the way, you get a $25 gift certificate if you allow us to come in. Okay? Please pay attention to that call, and please pay attention to what you tell that person when they're in to see you. Here's what we've identified with all this information. $100 million people studied. 75% of their cost came from diabetes, stroke, heart attack, Alzheimer's or dementia, and orthopedic/rheumatologic. So that would be rheumatoid arthritis, hip replacement, things along that nature. Cancer isn't even on here anymore. And we'll get into why with that. Okay? So the cost that comes with this, the decisions have been made because of all the efforts. And when I first started this, that's why I brought up managed care in '94. I didn't know what a PCP was. All of a sudden, I'm a PCP. I didn't know what a case manager was. All of a sudden, case managers are running the hospital care. Let me repeat that. Case managers are running the hospital care. You would get a call. Dr. Coppola, Mrs. Smith, who has pneumonia, has been in the hospital for 3 days. That's beyond her length of stay. Can I tell her she's being discharged tomorrow? They don't know Mrs. Smith is 100 years old. She has no family members. This pneumonia knocked her down. She's weak as a kitten, but her insurance will not allow her skilled nursing. So I told her she could stay for another day for physical therapy. I get a black mark. So we then get a report card of your length of stay being too much compared to, and what they always say is the best medical practice. Who's the best medical practice? The best medical practice are the doctors that they own, that they are able to keep their data with this part. They also don't take into the account the age and the acuity of the patient's, whatever their medical history is. But back to, this is what they identified, and these are the issues. So what they've now come up with is that their health team, and it's a distance, so it's telehealth. What's the catchword? Connected care. You're going to hear a lot about connected care. Remember, we're talking about it. Connected care. And that's a system that, through telecommunications, is going to connect all the telehealth people that are going to keep the diabetics, the strokes, the MIs, the Alzheimer's, the orthopedic, and the rheumatologic cases out of the hospital. Does everybody follow me? Because the hospital's costing too much money. And what they find is, this is what I thought was pretty amazing. It used to be 3 days in the hospital. Medicare gave you 21 days in the skilled nursing unit. How do I know this? I was medical director at Manor Care North Hills from 1990 to 1999. Okay? That's how I know it. That's what every insurance company provided. As long as you were in the hospital for 3 days. Who determined all that? Remember, I said till 1999. I had complete control. And again, it's so sad because the way they present it to you now is as if you're lying. It's not lying. If a 100-year-old doesn't have anybody at home and she's gotten so weak from this pneumonia, she's not going to be able to take care of herself at home. She's going to bounce right back into the hospital. That's not rocket science. So the rules came that if you were 3 days in the hospital, you got 21 days in skilled. 1997, they started what was called bundling of services. What does that mean? That means if you went in and you needed PT, OT, and speech therapy, before this act, each of them billed separately. So the 21 days that you were in the hospital providing the care from the PT, OT, and speech therapy, Medicare paid for everything. 1997, they said, no, we're not paying for all that. We're bundling the services. We give you one lump amount of dollars. What happened? Instead of 21 days, it went to 17. And then it went to 14 by 2004. And then depending on your Part C, usually 3 to 4 days, and then you have to be reevaluated. And I'm watching TV these last couple weeks in between my football games, and I'm hearing all this stuff about Medicare, like now's the time to enroll. And I hear them talking about how wonderful Part C is. And I think about what they're offering in my patients. So free eye, free dental, and free hearing. And most of my patients, if they're lucky, see the ophthalmologist once a year. If they have problems, the ophthalmologist gets them in frequently. And eyeglasses is usually not a situation that comes up. It's usually related to whether it's glaucoma, macular degeneration, or some other problem, or they're fortunate that after their cataracts they can see, or they got a lens implant, so I don't see a lot with the eyes. With the hearing, 90% of my patients that get hearing aids don't use them. Like they get them, but then they don't wear them. And dental, same thing. But that's what I see promoted, that go with this Part C. I don't know about the one they claim you can get money back, so that your Social Security check comes in and they talk about there's a plan out there that'll give it back to you. What I do know is the regular Medicare that you get through the government, if you keep that regular Medicare. Now, I don't know about supplements. That's all individualized based upon the person. But I can tell you, if you have the Medicare one that comes out by the government, it used to be called something 65. You don't ever need a referral, and you don't ever need to get things appealed. I can tell you that from my practicing, that the girls, I'll say to them, because I'm used to, I write a note, and then I'll write, Mr. Jones has back pain, let's check the LS spine, and I'll write the prescription. Dr. Coppola, you can't tell the patient to do that. We have to get it approved. So I've learned now, I don't say that to the patient. I wait till the nurse tells me. And so when I'm talking to my nurses and I say, can Mrs. Jones get so-and-so? What's their insurance? Oh, they're regular Medicare. Sure, they don't need anything. Boom. While my girls are right there and you're in the office, they set that up. They say regular Medicare. That's all I can tell you. My whole point to all this, and that's why I'm going through this all, is once they bundle the service and make the change, they have to have somebody pay for it. This coincided with Part C. And of course, who pays for Part C? A, hospital. B, outpatient. C equals A plus B plus 10% profit. I heard the laugh. Look it up. It's a fact. Shocked. I was shocked. And then when I did the first talk on this, it's bipartisan. Clinton put one in 1994, Bush put one in 2004, and Obama did the ADA in 2010. So it's both sides of the aisle. It's not politically like everybody thinks about. What it comes down to is dollars and cents. And the dollars and cents are pushing everything now to the point where they haven't succeeded in what they've tried, and what they're about to do and the changes that are making, you need to understand. Okay? So this is Part C. Part D, of course, is your pharmacy piece. Everybody's different. Guys, remember, I'm not telling you to get Medicare. I'm not telling you to stay with it. I'm just telling you what I see. I understand the cost. I understand people's budgets. I understand what you may or may not have to do. Maybe these Part C fit you perfect. But what I tell everybody is post-hospital care. 100 days. Why is that important? You want to talk to whoever you're buying your insurance from, and you ask them what your benefits provide post-hospital care in the first 100 days. That's your question. That's simple. And if they tell you nice as we're speaking and they run through everything, get a piece of paper because they'll have one. And you make sure you can go to, there's no LTACs anymore, they call it inpatient rehab, skilled nursing care. You make sure that home intravenous therapy is provided because that's a new thing that they're doing. They want you out of the hospital. Let's say you have open heart surgery and you get an infection and you have now what they call valvular heart disease, and because you have an infection there, you need 6 weeks of IV antibiotics. If you don't have the insurance, they're sending you home. And then based on when you go home, they cut a deal with the home care company. So you want to know, post-hospital care for the 100 days, what do you provide? Because you want to make sure you can go and get at least 2 weeks of therapy if you break. Now, it's different. If you want that hip done and you plan to get that hip done, I think it's fair for 7 days of coverage because you're planning everything. But if you fall and break it, you need a couple weeks. And that's the kind of stuff, that's why you want to ask them that question, because people think this is inexpensive, and then when they find they have restrictions on the post-hospital care and they're paying co-pays and deductibles every day they're in, all of a sudden this isn't as cheap as it sounded. So please pay attention to that. All right, so I've taken you through the process of what I've seen from 1990, and it's 2022. Whew, take a break. I had a lot of stuff I've been giving you. And unfortunately, we're only up to 2010. So I got 12 years to talk to you about. And in this period of time, that's when I've seen the most changes occur. And when I see the amount of money spent on trying to get you to join a certain Medicare provider or insurance company, I'm disappointed that they're not communicating with you to what's really happening with your Medicare today. And it's kind of, I have to tell you a story. My daughter got married, and I'm smiling. Don't ever give me a microphone is all I could tell you. So they made the mistake of handing me a microphone to tell stories about my daughter. And my wife finally made her alarm go off to shut me up, okay? But long story short, I had to tell a funny story. For me, it was a funny story. And again, I'll go through it real quick. Long story short, my wife hired a retarded babysitter, and when my wife asked me what happened and I said nothing, she wanted to know why my son was calling CYS, okay? So at the end, my youngest daughter came up and said, "Dad, you can't say that." And I say what? Retarded. And I said, well, that's what your mother said. And so, of course, she thought I was just blaming my wife, but she said I'm not allowed to use the word retarded, but I was allowed to say mentally challenged. So what I'm finding is you have to pay attention to the language. And it's so vitally important to listen to what you're asked, guys. So when someone comes into your home that you've never seen and they're doing an evaluation on you and they're asking you questions, think about what they're asking you. Be honest. I'm not telling anybody to lie, but think about what they're asking you, and you're always allowed to say, I'm not sure, because I don't want you providing information if you're not sure of why that person's in there. If you know they're coming, if you broke your knee or your hip and they're coming in to do home care, it's wonderful. And those people are usually very pleasant, very nice. You have a great relationship with them. Hope you don't need them again, but if you do, you call them back in your house. I'm talking about the one that calls you from your home care, or excuse me, from your insurance. All right, so what's happened that I'm so concerned about today? Telemedicine, and what they always use is best medical practice. Okay? Why I got concerned about this and why I wanted to talk about this today, I've been practicing for 33 years as a provider of health care. Before that, I did some other stuff. But in that period of time, I've never been questioned ever, ever, on my management of patients and care of patients. And I had a situation occur end of September. I had a patient with COVID that I played softball with, still do. Actually was in my daughter's wedding. And he is a, what's the word they use? He's a nurse at one of the systems, and because of all the COVID, he was going around and working to give all those people a break, okay? So he had the COVID, and he was providing this service where he would get called out. And so he missed a couple games, but I always throw a party in September because win, lose, or draw, we have fun, so I have everybody over for stuff. And I was giving him grief, and he said he still felt sick, like he wasn't tasting as well as he normally did. Long story short, I think he's 28. He didn't have a PCP. So I told him he'd have to come down to the office, and I wrote him a prescription. I'm not even going to write it because they made so much stink about it. But I wrote him a prescription because what he got in the hospital and what he had taken from the emergency room twice that he went to, he still couldn't taste, and he still didn't feel well. He was still fatigued. And I got called on why did I prescribe this medication for this patient that had COVID. Never has that happened to me. And so it hit me that my partner covers a nursing home. And he lives in India. So he went for 3 weeks on vacation to India. And while he was gone, he said, if anybody dies, put cause of death, COVID-19. And I said, I can't do that. I've been doing this 30 years, and we don't put the actual organism. We put pneumonia. They die of pneumonia. I never write strep, Haemophilus, whatever type of pneumonia, we write pneumonia. And he said, well, that's what they want you to write. I didn't write it. And then I had some people ask me to write things on the death certificate. And here I came to find out later that had I written this, that they would have got money to bury their person, and the facility where the person was staying would have gotten more money. And so it hit me that the financial situation and all the computerization coupled with AI, artificial intelligence. If you guys, I do have one because I'm into practice, so when I'm on call, I have to use this phone. And if anybody has one of these, if you're texting on this, it finishes your text sometimes, or it'll change your words. And it drives me crazy. But it knows what you normally write and what you normally say, so it's trying to help you expedite what you're doing. My whole point is the artificial intelligence is aware. So once again, guys, I ran you through the whole situation of what I've personally dealt with, and I go back to tele means distance. 1890s, the first electrocardiogram transmitted. Actually, there was a place in 1940 in Pennsylvania put the first X-ray through the waves. And now I saw it. Anybody ever skied? Water ski? The ski vest you put on? You button it on. The technology has advanced. You put one of those on. The doctor can listen to your heart, your lungs, do an EKG, and get an image of your chest. Like the dentist. Anybody been to the dentist? I hate the dentist, but I still go. When you're at the dentist, remember how I used to do an X-ray where you have to bite down on that stuff and they put that big thing? Now, like pictures. Same technology is there, guys. And once again, is it bad or good? The data hasn't shown yet. I can't tell you that having someone come to your house, take a history and do a physical on you is going to improve. And remember what they're after. The diabetes, the stroke, and again, the stroke and the MI, it's usually someone already had it, so they want to prevent another one. Why? Cost. It's very, very expensive. So their motivation to get to you is to help change so that you don't end up costing more money. Now, if that means to keep you out of the hospital, we're all for that. We want to stay out of the hospital no matter what. So I'm not saying it's bad. I'm just making sure. That's why I put, remember guys, I started it off. When was the first one? 500 BC. The Romans were going from community to community through messengers to talk about the health of the person. So that was the first telehealth, telemedicine. And again, from then to where we are now, I've done it for the last 30-some years, and I haven't seen a change. I've just seen trying to reduce costs. And as I told you, the first I got involved, 2016, at the place we worked at, we had to take call with these things where you would have an apparatus, so when the nurse wanted to send the patient out, we would get connected to the nurse at the bedside with the patient, and we would try to make the determination, are they going to do more at the emergency room than we can do right now? And so a lot of times we kept the patients at the facility longer and tried to implement whatever we felt was going on. Maybe a diuretic if we thought they were in failure, maybe an antibiotic if we thought they had an infection. We tried to do it that way to keep the person from going back, because remember, if they went back in 30 days, they didn't get paid. Does everybody understand the concept? Okay, guys, the purpose of today was to just wake everybody up. Please pay attention to connected medicine. Please pay attention to telemedicine. Please pay attention to people calling, wanting to come see you in your home to examine you. And again, I'm not saying it's bad. Please don't misread me. If you've been into the hospital and you get out of the hospital and that doctor wants somebody to look after you, that's called home care. That's wonderful. That's a good thing. I'm saying if your insurance calls and you haven't been to the hospital, and as far as you know, you're feeling fine and nothing changed, and now that insurance company wants to come out and see you, especially if they're offering you something, take it. I know a guy that got an umbrella. He was real happy. So take what they're providing. It's your insurance company, but be careful. Think about what they're asking you before you answer the question. And again, guys, I'm not trying to say anything bad about the companies whatsoever. That's not my intent. My intent was to make sure everybody understood what telemedicine is all about. It means distance, medicine from a distance. And that is either the mobile stuff we have now. We're not allowed to text, by the way. I'm not allowed to text on here to my partner, Dr. Jagiello. I'm not allowed to put on here, hey, saw Mrs. Jones, she doesn't look good, I might be sending her to Passman. I'm not allowed to do that. I'm allowed to put in there, hey, Ben, I'm sending a patient to Passive and call. I'm allowed to do that. And then when we're on the phone, we're allowed to say anything. But I'm not allowed to text it. So pay attention to that. Why? All that data gets out, guys. If it's on the internet, it's out there. Is it bad? Well, we don't have anything to hide per se, but it's amazing how I've had some patients, after they get these telehealth visits, all of a sudden on their cell phones, different information's coming in about what they talked about. Please pay attention. Question?
Doc, University of Pittsburgh has a program called All of Us they're promoting.
Okay.
I'm sure other people got their card. They want to know everything about you.
Sure.
University of Pittsburgh.
Sure.
What's the first stuff?
Sure.
Good or bad?
University of Pittsburgh is an insurance company. Don't forget that. And is it bad? I would say, now that I've talked to you about it, pay attention. Okay? And it's funny, it brings me up. When I was in college, I played soccer. And after practice one day, a company came in and said they would give us $500 if we allowed 3 physicals. $500 was a lot of money. That was in 1980. 76 is when I started college. So I took the money. Oh, my goodness. They hounded you. You'd walk out of class and they'd be standing there. You know, because they did a complete physical. They did the size, they measured your skin, they did all these different things. So beware of what's going on. And obviously, when you hear University of Pittsburgh, and it's a...
Refer to UPMC, it is University of Pittsburgh.
Okay, so that seems like a great institution that's done research forever. It seems wonderful. I can't knock it to say it's bad, but why? What are they looking for and why? And ultimately, if they're convincing enough to bring you in, just be careful of the information they're asking. Think about what they ask you before you answer. That's what I would tell you, please. At least listen to what they say. Repeat it in your mind's eye before you answer the question. Yes?
What was what were the words that you gave to say if you didn't know, or I'll think about it, or
I don't remember at this time.
I don't remember it.
At this time, yeah. Yeah, that's the one that you can get away with no matter what. You know, because they're asking you to think back about something in your history. I don't remember at this time is a way you can get out of that. And again, guys, please, I'm not trying to dissuade anybody from quality health care. I'm not trying to rip on your insurance companies, but I've been watching this for the whole play out from the ICD, DRGs, all the stuff I've been telling you. And what I see is they're trying to save money, and they're using that information you provide to them as a reason to or not to do something. And along that vein, my wife works for one of the companies, and she says to me that they're trying to pass a bill that physicians have to take a test when they're 70 years old for competence of mental status. And what I see with that is, again, what do they ask and what are they going to determine? I mean, I know a lot of doctors that should have quit in their 50s, but I also know, I don't know if you guys knew Dr. Snyder from Bellevue area, 98 years old, the guy was sharp as a tack. And my father told me never to retire. So I'm going to be a doctor somewhere for as long as I can. But the bottom line is that's the invasiveness that I'm talking about. That if this data is all to help you and your health, then I would think that someone would have told you, I'll leave you with, because we're going to talk about this, I think, in March. ACOs, Accountable Care Organizations. ACOs have been the standard of Medicare since January of 2021. Did you guys ever hear about that before? And yet they're spending billions on making sure you sign up with one of the Medicare providers from October to December. And that was a B, guys, not an M. Billions are being spent trying to get the millions of people out there to join their company. So what does it tell you? Remember what I showed you? A plus B plus 10%. The profit's built in. Good. Any other questions? Good, guys. Thanks for having me. Happy holidays.